we talk about the multidisciplinary approach, John, you alluded to it earlier. These patients need a lot of support. They can be fairly symptomatic. Eileen, how do you guys work at Memorial Sloan Kettering? Think your approach to this patient, what are some of the symptoms that you see, and what kind of pearls do you have for the folks out there to help them?
Yeah, I mean, we all know that this disease incurs a very high morbidity burden, and part of the challenge of maximizing the oncologic outcome is making sure we take care of the patient and address their symptoms. So optimizing nutrition, I think, is critical. Looking for any fixable problems, so pancreatic insufficiency, exocrine insufficiency is perhaps an unrecognized consideration for a lot of patients who walk in the door to see us. And it's so gratifying to hear patients, you know, give us the feedback that, wow, I feel so much better when I eat, and not having all these digestive issues. For some, it's very nice. I think if somebody has nausea and vomiting, it's more than just the cancer. So you're looking for another explanation, and the hidden one in this disease is duodenal obstruction. It's not that common, but I think as patients are living longer and doing better, we perhaps are seeing it a little bit more, and because there's less people going to the operating room for exploratory surgeries and having a double bypass, that's not so common these days. So, and having a good, your favorite interventional gastroenterologist help you manage that issue, and a more common issue is cholangitis, and making sure that patients' complications of biliary stents are addressed. I mean, that in itself is a lot of morbidity for these patients. Pain management is critical, and we use all the supports. Although I think for patients with newly diagnosed, untreated, I think our biggest tool is our therapies, and that if the therapies work, people will start to feel better. So if the pain is relatively manageable, we'll usually get by as in our team. But for those more complex settings, or certainly for people with progressive disease and pain challenges, I think having support from palliative care, from anesthetic pain management. Caio brought up nerve blocks can be done endoscopically, percutaneously. And it's a real art, I think, in terms of optimizing symptom control in this disease. But it's extremely important. So, you know, pain management, gastroenterology, our radiology colleagues to help us, our surgery colleagues on occasion to help manage certain symptoms. But it really is a team approach, and it's not an isolated specialty in terms of taking care.
And do you have recommendations? So pancreatic insufficiency, we see this so often. Our patients come in with diarrhea. Sometimes they mention it, sometimes they don't. It's associated with eating.
Often the spouse mentions it.
It's true, and sometimes you notice it in the exam room. And I'll tell you, I can't tell you how many times I've had a patient come in to see me who's taking one capsule and said, well, this doesn't work. So what's your thought, and you know, how far do you go?
So explain a lot and encourage people, you know, these are substances we all make, so it's not a tablet. You have to think of it as a natural substance, so that usually relieves some discomfort, and to take them right when they're eating, and that it's a titration process. It's not a perfect science, and that we may start with 1 and then go up to 2. If you're taking more than 2, we'll have them take half at the beginning, halfway through. Not an hour before, not an hour afterwards. They're wasted. And see if we can get the balance right. But it's, I think, you know, probably about 60% of patients, maybe even a little bit more, will have real tangible benefits from enzymes that are helpful to them.
And right away, you know, that night for dinner.
They think you're the best. They're like, oh my gosh.
Well, we are the best. But I agree with you, absolutely. You've got to put the pills on the napkin while you're eating, have the pill, or eat some food, have a pill, eat some food. I absolutely agree with you, and that's the way it's supposed to be done. So.
Now, Caio, you mentioned gastroparesis. I think personally this is one of the toughest parts of pancreatic cancer. They just get this chronic nausea and vomiting. They can't get anything down. What's your secret sauce for treating it?
Response. That it is. And that made the difference. You know, you know, through the years I treat patients with gemcitabine as a single agent, and that's a symptom that never went away. And the same with pancreatic insufficiency. I actually play, or used to play when I was an academic institution with the fellows, about the response at the pancreatic tumor and the pancreatic dilatation. And actually the patients, you know, pancreatic insufficiency going away, the burping, the early satiety and feeling full easily. So now we have regimens that actually have a response rate. It's quoted 1/3 with FOLFIRINOX, it's quoted 1/4 with gemcitabine nab-paclitaxel, but again, one is a central review, gemcitabine nab-paclitaxel, the other one is investigated, so we may be calling upon similar response rates. But you don't even need to have a RECIST criteria response to have improvement in those medications. So it doesn't need to be a 20% reduction in the maximum diameter, 30% reduction in the maximum diameter, but just be in the right place at the right time, and those symptoms get better. Now, when all this fails, we want to use our, Reglans and try to ask the patient to small bites, small amounts, more frequent. And also do not eat and sit, eat and move around and so forth, and eat more frequently. But I can attest that response makes a difference in this disease.
One of the things that bugs me still is the therapeutic nihilism of the community. I mean, a primary care doc or a surgeon or somebody who will say, it's not worth it, just go to hospice. And, this is really effective palliative care. And, oh, by the way, it extends survival. So, I think to right from the beginning just decide for a patient that this is a terrible disease and you can't do anything is one of the barriers we have to moving the bar forward in this disease.
Can I quote that randomized trial that is probably the very first randomized trial with best supportive care in pancreatic cancer? It's Neophthalmos and collaborators with, this is old 5-FU, and the patient had a good performance status. They had a toposide that is not an active disease, agent in this disease. They randomized patients to chemotherapy or to best supportive care with the caveat that at progression they could be treated with chemotherapy. So what we learned is that, first of all, improves survival was a small randomized phase 3 trial, but what is really interesting is that you cannot wait. If you wait to go to Disney World or, in our place to go to the Caribbean and come back, it's too late. When the patients, get ready to be restaged, their performance status deteriorated so much that they could not even receive drug. Yeah. So I think that trial was very important to me to discuss that issue about the importance of therapy and the importance of therapy now.
Yeah, I mean, you make a very good point. The pancreatic cancer patients, as we all too well know, can get very sick very quickly without any warning, and trying to get that treatment going before that happens is incredibly important. John or George, do you have any other pearls that you use for pancreatic cancer patients to help them through?
Well, I think the key is what was said earlier. You have to manage the patients. You have to be proactive. You have to address the pain, the nutritional issues, the psychosocial issues. You've got to get on the diabetes. You've got to really manage that. It's a tough patient to care for, but it's very rewarding when when things go well. So, and you got to be careful with your opiates. Opiates can also cause gastroparesis or slowing of the gut. Some of our drugs can do that. Oxali probably does that. So you just have to pay a lot of attention. It's not your typical patient visit. So.
Yeah, and until they get better, I like to see them often. I mean, this is the kind of patient it's not once a month visits. It's maybe every other week or even more often, depending on how they're doing, to fine tune some of this. And one other is I happen to live in not a state, but a district that, where I have to say medical marijuana is, and I take care of a bunch of 70-year-old hippies, now lawyers, who, have gotten it on their own or whatever, and in the right patient, I do think this may have benefits. So I realize we're in California, so the mood is right, but I'm interested, because I was pushing back against this when it first came out, and the more that I see our patients using, sort of pharmaceutical grade stuff, is that they do feel better.